Alright, welcome to the 19th lecture in our series on the chest radiograph. This lecture will continue with a discussion of the region of the heart, this time with a specific attention to the presence of abnormal air in the mediastinum. Let us begin by taking a closer look at this word, Pneumomediastinum. So, pneumo, meaning air, and I bring this up just to remind us about the appearance of air on a radiograph. As we discussed in several of the prior lectures, including the most introductory lectures, there are 5 fundamental densities, air being the black one. So air in the lungs, or air in the pleura, or skin, or mediastinum, is going to be this black color relative to soft tissue density, which is going to be more on the whiter aspect of the grayscale. So that's what we're going to be looking for. Things that are too black, out of place, other than the lungs. Alright, and then the back half of this word, mediastinum. So let's remember our anatomy here. We'll just do a little refresher. So the mediastinum is the anatomic region that extends from the thoracic inlet to the diaphragm, and then from the sternum to the thoracic spine. This thing contains the great vessels, arteries, veins, the trachea, carina, hilum, the heart, the esophagus, all of that stuff right there, sort of like that. Let's have a cross-sectional image through the heart. So take a slice right about there. We'll look at a cross-sectional cartoon. Blow this up here so we can get a closer look. And what I want to do is sort of dissect this thing out, show some of the layers here, and I'm hoping that later on in the lecture that this will make things a little bit easier to understand. So if we take the lungs and the heart and all these vessels and take all this stuff away, we're left with this right here, just the diaphragm, which is essentially a sheet of muscle all the way across the base of the thorax. Notice that it goes all the way across. Now I'm going to drop back in the lungs and the pleura here. Now, of course, on an X-ray or CT, they wouldn't be beautifully illustrated and colored like this. They would be black and white. So it's going to look more like this. The lungs are air-filled, of course, that's why they're black. The diaphragm is going to be that soft tissue density. And the pleura, well, remember that we won't see the pleura. It should be invisible on a radiograph unless it's abnormal. And what do I mean by abnormal? Well, if it's got fluid in it, like sort of layering like this might be, that would be a pleural effusion, right? Or if it's got air in it, like that, which would rise to the top, would be a pneumothorax. In which case, not only would we see some extra black stuff, we'd probably also see that sharp pleural line, that black, white, black, and we'll talk more about that in our next lecture, which will be concentrated on the pneumothorax. Now, the reason that I'm perseverating on this is that I want to point out this area here, this right here, where the heart's going to sit. That doesn't have any air density there. That part of the diaphragm that has air on it is the part that's covered with the lungs, right? So where the lungs sit, there should be black stuff, and where there aren't lungs, you shouldn't see any black stuff. Alright, this will be important later. Remember that I said that, and I'll bring it up again, of course. Alright, now, a few more things that I want to point out here, just so everything is clear. Alright, so this right here, this is the mediastinum. And remember that that's going to involve the central trachea, the bronchi, the esophagus, the heart, pericardium, esophagus, etc. Now what I want you to think about is all the different possible locations that air can originate from. There's about 4 of them here. So let's take a look. We'll pull this over to the side and we'll count them out. Alright, so the first one's obvious, right? That's the lungs, right? Lungs. Alright, the next one is going to be where the air gets into the lungs, the trachea and the bronchi. The next possible spot where you can have air originating from is the esophagus, right? You're swallowing some air, you're belching up some air. There's always a little bit of air in your GI tract. And speaking of the GI tract, air can also come from the belly. Well, how's that, right? We're talking about the chest here. What does that have to, how does it get from the belly into the chest? Well, turn this here, bring that in there. If we've got a situation where there's free air under the diaphragm from an abdominal surgery or perforation or whatever, that air can actually rise up through tiny holes in the diaphragm and manifest itself as mediastinal gas. So sometimes mediastinal gas can actually be from an abdominal source, and if the patient's had a recent abdominal surgery, this can actually be expected. Now that we've talked about where it can come from, now let's talk about where it can go. Let's talk about sort of all the abnormal locations that we could see air. So the first one would be here, it's outlining things in blue this time. That would be the pleura, right? Remember, the pleura is supposed to be empty, sort of a potential space, and as we mentioned before, we can get air there, and that's called a pneumothorax. Another possible location, which is the main topic here that we're talking about, is the mediastinum. We can get air in the mediastinum, and that's called a pneumomediastinum. And then the last place, which is a place that people don't often think about, is the pericardium. You can actually have air inside the sac of the heart, so that's called pneumopericardium. So these are the three locations in the chest that you can have an abnormal collection of air. And of course this is going to be a talk mainly focused on the mediastinum, so we're going to sort of focus on that here first. So coming back to our anatomy here, blow this up. And I want you to try and think three-dimensionally about this. So sort of laying that thing flat, right? And remember that air in the mediastinum doesn't have to stay there. It can rise, which it would do if you were walking around, up through those various fascial planes, and sometimes we can actually see gas in these like subcutaneous or deep tissues here in the neck. That can be a helpful hint that there is mediastinal gas, or there was mediastinal gas that's sort of rising and bubbling up in that location. And of course, it's possible also for mediastinal gas, depending on your position, to end up floating downward and end up in the peritoneal cavity. This is sort of less likely, but it can happen, and sort of think about that as a two-way street, because I'd mentioned earlier that you could have gas from the belly rise up in the mediastinum. Well, it can go both ways. So there's some overlap between the causes of pneumomediastinum and pneumothorax, and occasionally you will see both pneumothorax and a pneumomediastinum on the same patient. And when you think about that, there's two major possibilities or causes. So the first one is in a patient, let's say that's asthmatic or receiving positive pressure ventilation, they're intubated, you can develop a pneumothorax, not from rupture of the pleural membrane, but a rupture of the alveoli. So it's sort of like this. So we've got the endotracheal tube in place. It's pumping air under force into the lungs, out like this. If we take a closer look here, there's our alveoli. We have an increase in intra-alveolar pressure this way, like that. And what that actually can cause is a rupture of the alveoli themselves. Air can end up dissecting through the lung parenchyma, along the sheaths of pulmonary vessels, to the hilum, and then to the mediastinum, like that. In addition to this, that same mediastinal air can end up traveling through the mediastinal parietal pleura and end up producing a pneumothorax. So you can end up with a pneumothorax and pneumomediastinum, all from this ruptured alveoli. And of course, this stuff's not going to be blue. It's going to be black, right, when we're looking at a radiograph. So that's cause number one, which would be a ruptured alveoli. And then the second broad category is something like this. So if you have either a direct penetrating or closed trauma to the trachea or the esophagus, so injury here or injury here, remember we said these are both sources of potential air. Either one of these things, air can then dissect out through the mediastinal tissue planes, and then in some cases can continue into the mediastinal parietal pleura and enter the pleural space, causing a pneumothorax or pneumomediastinum. Sometimes one is more dominant than the other, but they can both be present if you look closely. So essentially you can have rupture of the alveoli from mechanical ventilation, asthma, various spontaneous causes, underwater diving, inhalational drug use, etc. You can have trauma, either penetrating or closed injury to the esophagus or trachea, and both of these broad categories can cause a pneumothorax and a pneumomediastinum. And then there's a third, miscellaneous category that can cause gas in the mediastinum, and I think about just some random things like mediastinal infection with a gas-forming organism, or, like I mentioned before, gas from the abdomen, either perforated bowel or perforated ulcer, or if they've had some kind of abdominal surgery that can end up causing gas there too. So these are the things that you should think about as the possible causes if you identify a pneumomediastinum and or pneumothorax. Also, you should think about patients who've had these various things, sort of set your pretest probability, as we've talked about in prior exams, as to if you're on the fence on whether or not a subtle finding could be real. Well, you know, if this patient is being set up for that, then it very well may be real. Alright, so this is sort of the general situations. Now, let's play. Let's imagine that we're in the PICU and we've had an emergent intubation under very stressful circumstances, and here we go. So I'm going to just sort of outline the airway for you here, and then I want to point out the position of the endotracheal tube. There. That's not good, right? So it shouldn't be possible, right, for the endotracheal tube to be below the carina, unless there's one particular situation where that is possible, which would be that endotracheal tube has actually perforated the trachea. That's not good. So let's take a close-up here, zoom way up, and I'm going to just sort of trace this black stuff. Remember, gas is going to be that dark density there on a background of white stuff, and as you can see that it actually extends from the mediastinum into the soft tissues of the neck. So this is a case of pneumomediastinum from a ruptured trachea, unfortunately iatrogenic from an endotracheal tube. Play a little bit more here. This time we're in the ER and we have a bulimic teenager who has now got chest pain after an episode of vomiting. So I'm going to highlight the abnormality here, both on the frontal and the lateral view, and then we'll talk about why it looks like this. So here and here. So just quick anatomy review. Remember, this was our cross-section that we looked at earlier. And I'm going to remove all this stuff, lungs and heart, all that stuff. And remember that we talked about how the diaphragm was just a continuous, smooth muscle across the base of the thorax there. And that the only places that we should see air are where the lungs are sitting, right? And we're not supposed to see air here because that's where the heart and mediastinum and all that stuff is. But imagine a scenario where we had air leaking from the lung or from the trachea, esophagus, etc., that was depositing under the heart here, like that. Now let's flip this thing around and sort of make this 3D for you. Think three-dimensionally. Imagine that here's the patient's heart. Bring that over here. Now take a look at the base of the heart on the radiograph, here and here. there's air there, right? That air should not be there. There can only be air under the heart if there is mediastinal gas. So taking a zoom back up at the original film here, this is referred to in radiology text as the continuous diaphragm sign, or it looks like the diaphragm stretches all the way across the base of the heart. So by reviewing that anatomy, you can see that you should never have gas there. That can't happen unless there's air in the mediastinum. Play a little bit more here. Now we've got an older gentleman who has experienced severe chest pain after choking on a Dorito. So I'll take a closer look here, and I want to sort of draw your attention to this region right here. So outline the aorta. Draw that sort of main notice. There's a little bit of air density there outlining the aorta. Here is the follow-up. You can see that it's gotten worse. And we'll zoom in. Hopefully you can see this a little bit better. And I want to point out to you that it looks like there's a black ring or air density around the aorta. So this is referred to in radiology text as the ring around the artery sign, or the tubular artery sign. And in addition to this, we've got gas sort of extending up in the superior mediastinum. There's also a large amount of subcutaneous gas here and here. That way. So this is a good picture for extensive pneumomediastinum here. Play a little bit more. Here's a peds case. Alright, so it's funny looking. And let's look at a case from the prior lecture. You may remember this guy here. Remember that we discussed how this triangular shaped mass at the right heart border is actually the thymus. And in the kids, we sometimes call this the cardiothymic shadow, because the heart shadow also includes the shadow of the thymus. We discussed in the prior talk that in children less than 5 years old, particularly in infants, the thymus can have a wide variety of different configurations. That it can be wide, rounded, you can have a triangular opacity there like we have in this case, or sometimes it just sort of like a bulging that blends in with the right heart border. It can be variable and different, but not look like this case that we have today. The C was angry. C was angry that day. It was angry like an old man at the deli trying to return soup. But luckily we had our sailboat with our Spinnaker sail on it, one of these things. So I'll bring that up because some people will say that that looks like a Spinnaker sail. Lots of different sail signs in radiology. This one right here is the Spinnaker sail sign. And what this is trying to show you is that just like on the ocean, the sail is being lifted by air. With a closer look, we may notice that there is some air outlining the heart, and in the upper mediastinum and neck, and sure enough, this kid has a pneumomediastinum that's elevating or lifting that Spinnaker sail, which is the thymus, up. So it creates that appearance there. So this is a classically described sign in pediatric radiology for a pneumomediastinum. And this is one of the situations where, earlier the thymus can cause a lot of confusion and be a hindrance because it's scary, especially when you're first starting out looking at these things. Try not to call it a mass. Here it's actually useful when it's elevated because it helps us identify that this kid indeed has some abnormal mediastinal gas. Sure enough, a little bit up there in the neck as well. Alright, another case here, slightly different this time. You can notice some abnormal gas around the heart, here and here. I want to point out to you that the air does not extend above the great vessels, here. So just to return to a prior slide where we talked about different locations outlined in blue where air can abnormally be located in the chest. We said that it can be in the pleura, we call that a pneumothorax. It can be in the mediastinum, call that a pneumomediastinum, or the third category, and I said that people don't often think about, which is this pneumopericardium. Sort of move this up here, I'll bring in some cartooned anatomy. I'm going to make a point here, so just sort of highlighting these various areas here. And I want to point out that out of these three possible choices, there's only one of them where the air stops at the level of the great vessels. See that? With the pneumopericardium, it doesn't go any higher than that because it's stuck in that sac around the heart. So if we go back to our case here, and we again notice that that air is again limited, or it doesn't ascend above the great vessels, just like that, this is what we've got here. This is a pneumopericardium. Just a few pearls on this. Pneumopericardium can mimic pneumomediastinum. You typically will see a pneumopericardium after thoracic surgery, or in some situations a penetrating injury to the chest. And I like to think about it like this. Pneumothorax is very common. Pneumomediastinum is kind of common, but less common than a pneumothorax. Pneumopericardium is rare, very rare, and that's probably the reason why people don't think about it very much. So the thing that's helpful is the presence of air around the heart that does not extend above the level of the ascending aorta. Air in the mediastinum typically is not it's not restricted like this, so you'll see little dots of it sort of rising up given enough time. And if you're not sure, we'll have some problem-solving strategy, and we're going to talk about that a little bit later here in the lecture. Now there's one more case here, something that I want to point out. This one is just a little bit different. So let's pretend that we have a radiograph for a routine situation. Maybe it's a school physical. Here we go, and I'll window this here, just like that. And I'll see if you can see sort of a black line right there. Huh, does this kid have pneumomediastinum? That's weird. This kid's got no symptoms. Show another case. This is a different patient, something similar looking. This time on both sides of the heart. I'll tell you that this patient also has no symptoms. It's sort of a strange, but sure enough, there's a black outline around the heart. What do we do with that? So this is actually an optical illusion. I'll talk to you a little bit more about this because it's fairly common, and it's probably the most common mimic of a pneumomediastinum. Let's talk just briefly about optical illusions, and this one in particular. I'm going to show you 5 shades of gray, and I'm going to tell you that these things are totally homogeneous. There's no gradient within each one of these blocks. So if we take a zoom up here, we look, and I'm just going to draw 5 little boxes inside this one. I just want to prove to you that each box is the same as the box next to it. They're all totally homogeneous. And each one of these rectangles from the beginning is just like that. Each gray bar, totally homogeneous. No gradient in between them. Now watch this. I'm going to bring them close together. Alright. Now remember, there's no gradient there. And I want you to look right here, like right there. Does that look a little bit darker, like right at that edge to you? Let's do this. I'll move them apart, move them back together. Do you see that? Look like a dark line. Moving them apart, moving them back together. Right sort of here. And on the other side, it looks actually just a little bit lighter. Alright, so this actually has a name. These are called Mach bands. How it looks a little bit dark on one side and a little bit light on the other. And it's an exaggeration that occurs between edges of slightly different shades of gray. And you see it when they come in contact with each other. You don't see it when there's a little bit of a gap, but when they come in contact with each other, then you see it. And the reason that you see it is because of this mechanism that exists in your visual system that enhances edge detection, and it's called lateral inhibition. I'll just share with you briefly how this works. because I think it's interesting and it's helpful to understand it. So let's, have a look at the eyeball here, and we have to take a close look. Now, if we looked in here real close, we'd see a whole bunch of fancy stuff. Horizontal cells and these omocrine cells and, neurotransmitters and all these kinds of signals that are going off. But let's simplify it. Cones and rods make up the basic elements of the vision machinery, and there's a series of connections that these things go through, and when they see light, they're going to transmit that signal to the brain. So sort of something like this. So they see light, and they say, transmit that to the brain, and the brain sort of has a board there, and it's like, there, that's what you see? Okay, all right, sort of like that. But there's a little more complicated than that. They just don't transmit this signal directly. They actually inhibit each other. Each cell inhibits the one sort of immediately adjacent to it. And the more light that they see, the more they inhibit. It's sort of something like this. So he'll transmit signal forward, but he'll also have a little bit of lateral inhibition up and down. There. But everything evens out because they're all seeing the same amount of light, so they're all inhibiting each other equally, so it becomes homogeneous, like that. So back this back out, and like I said, even though we're all seeing signal and everybody's getting a little bit of inhibition, which is dampening the signal, the overall signal is still homogeneous. But now if we cut it to just 2, and we're going to try to keep it simple by doing it that way, I want to show you what will happen if we've got one cell that's seeing some bright light next to another one that's seeing a slightly less bright light. So this is a situation where we don't have that lateral inhibition. Just pretending that that doesn't happen, the brain would see something like this, where there is indeed sort of an edge there, a little bit of a gradient that it's going to see. But now if we add that lateral inhibition in, because I said that the more light you see, the more inhibition you give, this guy here, he's going to have a lot of inhibition, and this guy on the top who has seen less light, he's going to have some inhibition too, but not as much. What that's going to do is amplify the difference between those two, where it's enhancing the edge like that, where he gets diminished but the other guy gets diminished more. And the brain is going to see that end product sort of side by side like this, or maybe easier if we pull them like that. And you can see that the one that has the enhanced edge, it really sticks out that there's a difference between those two, and that happens because of this lateral inhibition. So why does your brain do that? It seems like an awful lot of trouble. Well, you can maybe imagine a couple of scenarios where having the ability to distinguish edges clearly, especially in a grayscale environment, would be useful. So let's imagine that we're in the forest and we're walking. Maybe we're having a picnic, and then the sun goes down and it begins to get dark. All right, spooky, I know. We'll zoom in here. Now I think you'll be able to see that being able to detect edges in a grayscale environment might have an advantage, maybe in spotting trouble. So, alright, so that's why we see those edges with a little band of dark there and a little bit of light on the other side, and that's this lateral inhibition process. And that's what your eye is doing to enhance edges. And even though this might be great for spotting bears in the forest at night, it can actually cause some false positives when you're looking at another grayscale image, chest x-ray. Alright. So often, when you're looking at a normal chest x-ray, you can see a thin, well-defined black line around one or both margins of the heart. And like I said, this is actually an optical illusion called a Mach band, or some people call it a Mach effect. Now, you'll see this so frequently that you'll get pretty used to ignoring it. And the main thing that's helpful is that clinically just makes no sense for this patient to have a pneumomediastinum. But if necessary, you could repeat the study or do a little bit of problem solving we're going to talk about right now, actually. So just a quick summary, and then we'll talk about some problem solving. So we can have a sharp black line around the heart for a couple of reasons. We can have, that can be air within the pleural space, it just happens to be next to the heart there, pneumothorax, or it can be air in the mediastinum, a pneumomediastinum, or rarely air in the pericardial sac, which people call that a pneumopericardium, and even occasionally you can have this Mach effect or Mach band there. So how might we tell them apart? Well, we can dig into our bag of tricks, and we can use this thing here, the lateral decubitus. We've mentioned this in a couple of talks here, I think most recently maybe with our air trapping lecture. So we're going to break this thing out again to use it for some problem solving. So here's our black line right there. Now let's see what happens when we're going to start turning the patient around. So I've got sort of 3 different scenarios here, depending on the etiology. So starting with the pneumopericardium. So here's our black line. We turn our patient this way. Air's going to rise, right? So it's going to sort of look pretty similar, but when we turn the patient around, that air is going to flip sides and now be on the opposite side of the heart, right? Because it's going to redistribute to the top because it's floating. Now in a situation where we've got pneumomediastinum, turn the patient this way and it's going to be sort of right in that location, right around the heart like it looked before. But if we turn them around, it stays there because it's sort of trapped in that those mediastinal fascial planes and fat and all that stuff sort of hanging out in there. So we don't expect it to move in the setting of a pneumomediastinum. It should stay put. Now, pneumothorax, when we turn the patient on the side here, it's going to rise up, right? Again, so it's going to rise all the way to that most lateral aspect of the pleural sac adjacent to the chest wall, and if we turn the patient around, it should again rise all the way up to the, it's trying to float, and it's limited by that pleural sac, so that's how you would expect it to look. So sort of a quick summary here again. So these are our 3 choices. I'll move this up here. All right, so remember, this is all going to work basically because things are floating just like air-filled balloons. So in the situation of the pneumothorax, when we turn the patient upright here, it's going to rise up and be against that most lateral portion of the chest wall. The mediastinum, we're expecting it to stay put, and the pneumopericardium, we're expecting it to stay put on one side, depending on which side it's on, but then when we flip the patient around, it's going to go the other direction. So as we flip the patient around here, again, that air in the pleural sac is going to rise, the pneumomediastinum is going to stay put, and the pneumopericardium is going to redistribute to the other side of the pericardial sac. Now, for the Mach bands, often they'll go away. You certainly won't see any redistribution. Sort of as you put that lung down, it's going to become more white, and it's going to be closer to the density of the heart. You'll often see those things just disappear completely. I hope you enjoyed the lecture. If you'd like to see more lectures like this, you can go to teachmechest.com. Sign up for a free 7-day trial. This free trial gives you full access to the website, where you can find more than 30 didactic lectures similar to this one on all the topics you need to master interpretation of the chest X-ray. In addition, the free trial also gives you full access to more than 50 cases with the IRAD platform. Go to teachmechest.com now to join the radiology revolution.